So that way, and then the last meeting, they just move you around.
Yeah.
I can change where I want to.
Yeah, I really want to have like more.
Right.
Whoever wants to have credit, but at least have the power to do it.
I feel like the nursing care down to like the week where she was lucky because Michaela was a great president. Had a great meeting. I was like, oh no.
This is what it looks like.
Like,
You don't
say,
what do you got? You should have the email that they give you. That was
Not so much for immunization. No comment. Yeah, right.
And I didn't. It said in the thing immunization.
I
I
believe
know,
it.
but I emailed her. She finally responded right now to my email.
Did she reply to you?
She good.
Yeah, she said, please, if you would resubmit forms provided through AMR on WWW blah 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 blah. I have her information submitted.
Yeah, it's true.
So she wants.
So we're on.
Okay.
Thanks.
Yeah, I don't know if they are.
Yeah.
All right, so it's 3:05. Let's get back to work, shall we?
That was not part of immunization. The email address specifically says like immunization, student immunization Scotland.
By the way, have you noticed a difference in me from this semester to last semester? This is me teaching what I like,
Oh.
not teaching what I have to teach. All right, so now let's talk about the role of nursing in birth. You have several roles, just like always, and you know all these roles already, right? Care provider, critical thinker, communicator, teacher, collaborator, advocate, yeah. Okay? So those are the roles for nurses. The same roles you've always had in every field. They changed just a little bit, you know. Definitely advocate is a powerful one. Communicator, collaborator. This is one of those aspects where you collaborate a lot on every single patient, okay? Every single patient is going to need a labor and delivery nurse. She's going to need a provider to catch the baby. She's probably going to need a baby nurse, someone to take care of the baby when the baby is born. She's going to need, she might need, you know, anesthesia to provide epidurals or whatever. And so where, you know, in other specialties, you usually have the doctor and the nurse, and once in a while physical therapy or social work, something like that. In birth, it's definitely a team approach. Now, more and more hospitals are going to a type of team approach called the team steps process. If you've worked at WOMAC, you've probably heard team steps, especially if you get into obstetrics at WOMAC, you'll hear a lot of team steps. They're picking it up in the operating room and using it more there too. But it comes to us from the airline industry. It's a style of teamwork in which the team is all, at least on the surface, equal. Okay? And every member of the team has the power to call an all stop. This is a safety stop. It has everything stops right now until we get this figured out. Okay? They use they use huddles to make sure they're all on the same mental model. They use post-event briefings to make sure that they process and, you know, do it better next time, and that they work on, you know, any bad feelings they have. There's a series of not process. That's what I'm looking at when it's fighting.
Conflict.
Conflict, thank you. A series of conflict resolution tools, like the 2-challenge rule. The 2-challenge rule says, hey, this is the nurse. Hey, doctor, I think that this is, you know, I'm not really comfortable here. Okay, well, that's fine. All right, no, really, doctor, I'm not really comfortable here. We need to, that's a second challenge, okay? When you've done a second challenge and not gotten the response you want, you kick it up the chain to the next level, okay? They do things where they work on, you know, it's just several conflict resolution models that run through, and they work under these acronyms called I'm Safe. Like one of them is I'm Safe, and it's like it's basically, you know, each person on the team has to be able to say that they're safe. They slept well, they ate well, they don't need to pee, they've been able to take a break or whatever that they need, they're not on drugs, it's the I'm safe pathway. It's a very interesting way of doing obstetrics, and we do it very, very well at Womack, at least on the surface. There's still the same problems where the nurse will say, well, I'm perfectly okay with this, and the doc will say, no, I'm not okay with this, and then they have to work on it a little bit better. But it's better. I think it's better at Womack than it is anywhere else I've practiced obstetrics. And that's saying something, because I've practiced obstetrics all over the place, So Womack does a pretty good job. All right, on to chapter 2. Obviously, we're not going to make it through chapter 4. I'm probably going to start speeding up a little bit. So, contemporary issues in women's families and children's health care. So, I hate when they do this. So there are several different models, and the book likes this intervention wheel, okay? Talking about obstetrics through a population-based model. Now, sometimes I'm looking at these slides going, yeah, I don't like that. And then I start talking about going, well, I'm okay with it. So the important thing to understand about birth from a population health experience is that the way we are born impacts our entire lives, okay? It changes things. And when you can make a little change here and then consistently make that happen at your hospital, you're going to consistently change down the road. It's going to grow. It's going to become population-based. The most famous example of this is breastfeeding. Okay? In 2012, the U.S. Surgeon General Regina Benson came out with a call to action to support breastfeeding, and she called formula feeding a public health crisis, saying that we know that babies who are formula fed are not as healthy as babies who are breastfed. And if 50% of Americans are giving their baby substandard nutrition at birth, that's going to impact the entire population as it moves out. Okay? So it's not just a matter of what you're doing with your baby, but it has a global influence in the community around you. With every child being just a little bit less than they could have been, and then it kind of it blossoms. Okay, and then 2 or 3 generations that way, you get worse and worse and worse and worse. My favorite example is actually a really, really bad B movie that came out last summer. I can't remember the name of it, but this guy was put in suspended animation for like 500 years. And he's just an average guy, 20-something, not a rocket scientist, not particularly bright, just an average guy. But he's put in suspended animation for 500 years, and when he wakes up, he's the smartest person on the planet. And everyone's like, wow, you can read, that kind of stuff. And they're just a bunch of morons. And it speaks to how, we're dumbing things down. And then in 500 years, will we be the same as we are today? And that's a drastic example, but it's true that, with every generation, we have the opportunity to make things a little bit better or a little bit worse, and they accumulate over time, okay? A specific example of this is World War II. Who knows how tall the average infantryman was in World War II? 5'2". 5'2" was the average full-grown man in World War II. That was just 70 years ago, okay? And they weighed about 105 to 120 pounds, okay? They were little. They're the same species we are today, right? My grandfather, why was he so little and I'm so big? Because of nutrition, okay? Because we are eating much better today from the moment we're born on. And from a population perspective, it gets bigger and bigger and bigger. My favorite example is Samoans. Monster people, right? Have you guys ever met Samoans? They're huge. And that's on purpose. That's not an accident. Okay? Because in Samoan culture, the ability to eat well is a mark of your family's affluence. The more you eat, the more you're bragging about how rich your father is. And so well-fed children that grow up big and strong show that they've got good parents who can provide for them. Okay? And so when that culture repeats itself year after year, generation after generation, they get bigger and bigger and bigger. Okay? And we see that in American culture too. Can anyone define a good baby? What's a good baby? What are the aspects of a good
One
baby?
that sleeps through the night.
One that sleeps well, and what else? And eats well. And one more.
Healthy weight.
Grows well. Exactly. What is a good baby? A baby who eats, sleeps, and grows. No, that's not a good baby. But that's what we like to believe, okay? And so we put this emphasis on big, fat Gerber babies, right? And so we don't know if we're making healthy babies or not making healthy babies. But everything a mom cares about is my baby eating okay, sleeping okay, growing okay. And the pediatricians reinforce it. Whether it's good or bad is not, it's irrelevant. It is what it is, okay? And so, and so that's the population basis to obstetrics, that the more we do it, the more things are going to happen, okay? This is an intervention wheel. Whatever. Okay, let's see how it works. So, Healthy People 2020. God, I hate that. There needs to be a remove all animation in slides. I hate those things. So, Healthy People 2020. Are you guys familiar with Healthy People 2020? I think we talked about this last year in nutrition, right? It started out with the Healthy People 2000, became the Healthy People 2010 because we failed, became the Healthy People 2020 because we almost made it but not quite. So yeah, so it's going that way, okay? It defines our healthcare priorities and it guides us toward goals. And you know, the goals are basically to achieve a healthy life and equity, and everybody is you know, singing Kumbaya and being happy. In birth, we have some specific ones. We're going to move forward just a little bit. Yeah, 42 indicators. We are not going to talk about them, okay? But the big ones in birth are decreasing our C-section rate, increasing our breastfeeding rates, decreasing readmission, decreasing maternal mortality, those kind of things. And you'll see those mentioned over and over again in obstetrics. And they focus a lot on the prevention. I did not spend as much time with these slides as I should have. I'm sorry. So this is an interesting statement, that the population is healthier than ever before. Okay? Heart disease is declining. We're living longer. I would tend to agree. Okay? However, can anyone tell me the only industrialized nation where maternal mortality is increasing, not decreasing? Yep, us. Okay. From a population perspective, if you survive birth, you're in good shape. Okay? But we are struggling in America to we're not doing birth right. There's something wrong with how we do birth. And we can't really put our fingers on it. Okay? Whoever you ask has a different opinion. And you know what opinions are like. And so, so we're struggling with how we're going to do this. But we are the only industrialized nation, the only first world country where our maternal mortality rate is on the rise. And it's not on the rise a little, okay? It is skyrocketing, like from 3 in 100,000 to 11 in 100,000, like tripled in my lifetime, okay? And so while, yes, we are in general living longer and living healthier lives, thanks to public health and you know our population focus, we're not doing so well in the birth arena. And I've read a dozen articles on the topic, and they're all different. Okay, one aspect is that in America we count infant mortality different than they do in third world countries. That if a baby is born at 22 weeks in America, we consider that a live birth. And then when that baby dies, that messes with our numbers. Whereas in other countries, a baby born at 22 weeks or even 28 weeks doesn't stand a chance of surviving, and they don't even bother counting them. They count them the same way we do 18-weekers who are born. Okay? And so if you're not counting 5% of your newborn population or 1% of your newborn population, then you're going to have a lower infant mortality rate than we are. But that really doesn't answer the question in America, because we're not too totally different than the Europeans. We're close, and their number is still a lot lower than ours. And a lot of people say, well, Americans are fat. And fat people, when they get pregnant, they have more complications. They certainly do. We know that if you're obese, your risk of complication in childbirth goes up dramatically. And so there's something to be said for that we're not as healthy going into pregnancy as we should be. But it's kind of interesting to be overnourished, and that's a bad thing, okay? But that only explains a little bit of it. That doesn't explain a lot of it. And then the other one is that we have women in America who are getting pregnant who can't get pregnant anywhere else. Our reproductive endocrinology is amazing. We've learned how to make singletons, triplets, and twins like nobody's business. We are very, very good at it. And I've seen it happen. I had a woman in Womack 2 years ago who had a cardiomyopathy. Okay? Cardiomyopathy is a bad thing. It's your heart doesn't beat as well as it should, and you can't get blood to your body. All right? And if you have cardiomyopathy, your chance of death during pregnancy is like 60%. Okay? Someone got her pregnant, like reproductive endocrinology got her pregnant. She couldn't get pregnant on her own, and she went to the infertility treatments, and they got her pregnant. She couldn't get pregnant because she wasn't healthy enough to survive pregnancy. That's why she couldn't get pregnant. Okay? And you know, diabetics and heart disease and high blood pressure and asthma and polycystic ovarian disease, and all of those folks are women who used to be infertile, who are now fertile thanks to the miracles of modern medicine. And so there are a few of those that are not surviving childbirth as well. Okay? So, what's that?
Then you have age.
Age, that's another one, is that we're getting older and we're having babies later in life. Okay, and we know that as you get older, you have more complications in childbirth. Not because childbirth is harder, but because you got more years on you. You know, my car with 100,000 miles is not going to handle revving in the red line for as long as a brand new car that's just right off the factory floor, right? It's got you know, its little aches and pains, its little breaks here and there, and it's going to break down more often. So the older you get, the more likely you are to have complications, just because you've got more wear and tear on your structures when you get pregnant. And so they struggle a little bit more. So people who are pro-American obstetrics cite all of those things. You know, we're fatter, we're not as healthy when we get pregnant, we're older, we got reproductive endocrinology. That's why there are so many women dying in America. But those same problems happen in other places too, just as well. I mean, it's not like America has a secret in reproductive endocrinology. But there's something else that's going on. And, you know, and so when you ask the midwives, we go, I know what it is. Don't be a bonehead. It's what you do to women. It's your 50 to 80% C-section rate. How about that? Okay? I'm going to tell you guys a little secret. We have had like 3 women die at Womack, okay, in the last like 2 years. That number is ridiculous, okay? It should be less than 1 in 10,000, and it's 3 in 10,000, okay? It's a ridiculous high number, okay? And you know, one of them was just like I described. A woman who was morbidly obese. She had an abruption at like 26 weeks. Her baby died. She had an emergency C-section and went home to New York to bury her baby 2 weeks later and came back and died of a blood clot. What were her risk factors? Morbid obesity, surgery, travel, right? Those 3 things are going to kill you like that, okay? So, you know, okay, fine. She's one of those who probably shouldn't have gotten pregnant until she got her BMI under 50. Yeah. Okay? But it happens all the time. And then everybody heard about the woman who died after having her tubes tied? No. Oh, that was all over the news. She died the next day, bled to death. And it was a mistake, clear and simple. Plain and simple, the emergency room didn't recognize it. So she had her tubes tied, and in the morning, and at 4 o'clock in the afternoon came back to the emergency room with incredible abdominal pain and waited 4 hours to be seen. And after 4 hours, her breasts were killing her. She had to get home and feed her baby. Her baby needed her. He was only like 6 months old. So she had to get home and breastfeed her baby, so she left without being seen. And her 8-year-old found her unconscious the next morning, and it was too late. She bled to death overnight. And so, it's sad because her doctor was in the hospital, still in the operating room. All they had to do was go, hey, your patient from this morning was here. And that's the way it was supposed to work, but she slipped through the cracks. Okay? And so, when women die in childbirth, you have to look at everything very specifically and find out, why did this happen? What's going on? That kind of thing. And frankly, it's not happening across America as well as it should. And they're not actively looking at what happens when it happens. Most maternal M&Ms. An M&M is a morbidity and mortality report where you have a bad outcome, all the doctors get together and review the case and see what happened. Did you hear what I just said? Did the whole team get together?
No.
No, only the doctors. So they only got one perspective. No diversity in that group, right? And so, you know, and it becomes a, how can we make ourselves not at fault? Okay? And in the military, it's not nearly as bad, because in the military, we don't have to worry about being sued. You know, if you're going to sue the government, you sue the government, not me personally. And so I don't have to worry about protecting myself. I can be open and honest with myself about it. And that's why I can talk to you guys like this about this. Because, you know, now in Cape Fear, it's not immune to it. In Cape Fear in 2013, do you know they did a C-section on a woman who wasn't pregnant?
What?
Yep. A woman, a little bit obese, was able to convince the resident that she was not only pregnant, but in labor, and had a classic C-section, needed to have a C-section. Okay? And so they no ultrasound, no prenatal records. She was yelling and screaming and making all kinds of noise. It's obvious that she needs a C-section quick. Run to the operating room, cut her open, and she doesn't have a pregnant uterus. Yep.
She's crazy.
Because she's crazy. There is a form of mental illness where people want surgeries that they don't need. It's one of those body dysmorphic type disorders. There's something wrong with me. There are people who cut their limbs off all the time. You know.
Well, now she has the scars and she can say she's had a C-section.
Yeah. Yeah.
Covers the attention.
Yeah.
Just like the
And
mothers
so-
that kill their kids for attention.
It's more to it than just attention, but yeah, it's a mental illness. And I always say, if mental illness made sense, it would be called logic. Okay, mental illness is not supposed to make sense. That's why it's mental illness, right? But there's something inside. I mean, it's just as bad as Bruce Jenner becoming Caitlyn Jenner. It's just a body dysmorphic disorder. It's just I'm not happy with the way I am, and I'm going to change it. Right? It all falls under the same umbrella. Okay, but so yeah, and these things happen all across the country. And when you do abdominal surgery, there are risks to abdominal surgery. You're going to nick a bleeder. You're going to you're going to go through the bladder. You're going to encourage. You're going to find scar tissue. You're going to get infections, and they add up a little bit here, a little bit there. Sooner or later, you're not going to be lucky, and someone's going to fall through the cracks, and they're going to die. And that's really where the midwives think that the increased maternal mortality is coming from. It's just not enough attention to detail in the little things. Not enough acceptance of what's normal and not normal, you know? The urge to put Pitocin on when you really don't need it. You know, the urge to make people as comfortable as possible during birth, even if it's dangerous to them. You know, that kind of stuff. It just adds up. Definitely, we spend more money than any other country in the world on obstetric care. And we don't have as good outcomes as we're supposed to. Okay? Our per capita spending is enormous. Why? Because Americans believe if there's a problem, you throw money at it. If there's a problem, buy a new gadget and it makes it better. If you got a problem at home, you buy a new computer or you get a maid or whatever. You spend money at the problem. Because we have so much wealth, we can throw it away. Okay? Countries that don't, they don't have that worry. Okay? There's a fascinating thing that's happening right now. Over the last 10 years, we have spent $10 billion through the UN funding antibiotics and Pitocin in third world countries. Okay? Sending, you know, Ethiopia and Djibouti and the little teeny tiny third world countries all over the world, sending them antibiotics and oxytocin, with the thought that antibiotics and oxytocin are the two reasons, the lack of those two, are the two reasons that women die in childbirth in the third world. And it's true. They die of infection and they die of a postpartum hemorrhage. And so if you can send those two drugs, you'll make an awful lot of stuff better. And so they threw money at the problem. And guess what happened? It didn't help. 10 years of effort, $10 billion, it didn't make it any better. Because they forgot the little thing. And that is that at the end of that money is a human being. Okay? And if you're in the middle of the Ukraine at 2 o'clock at night and you've got a woman who's bleeding to death and you need that power, that oxytocin that they sent from the United Nations, and it's so expensive and we have to have it, we have to protect it so we don't waste it. So the only person who has the key to get into the oxytocin is at home. And now they got a woman bleeding to death and the drug is right there and they can't access it. Okay? So little things like that they forgot. Okay? But it's not about the money. It's not about how much money you throw at the problem. It's about getting the processes worked out. You know, going step by step. And so even though we spend an awful lot of money in America on our healthcare spending, we're not doing very good. And they still talk about healthcare disparities. And there's a huge disparity in the system where and we've all seen it, that there are different ethnicities that do better or worse in different diseases. And sometimes it's socioeconomic, sometimes it's environmental, sometimes it's diet. But there is a lot of healthcare disparity out there. And one thing that I find very interesting is I love being in the military because we have kind of a socialized medicine thing. And so we get everybody in the military gets 100% unfettered access to birth control, obstetric care, all that good stuff. Guess who doesn't get as good outcomes as the civilian world? Military. Our outcomes are still not any better than everyone else. Isn't that funny? It's not about access. It's about whether or not you choose to access it. Our unintended pregnancy rate is just as high or higher as in the civilian world. Even though all you got to do to get a contraception is show up at 6:30 in the morning on sick call like everyone else who's got a sniffle or a headache and get birth control. And it doesn't take but 5 minutes. And they're not doing it. Because it's not about whether or not it's free, it's about whether or not you think you need it. Okay? And young soldiers don't think they need birth control, and then they end up getting pregnant. Go figure. Right? So there are healthcare disparities out there, but it's not as simple. Just like whether or not our mortality rate is actually higher or lower, it's not as simple as it sounds. Okay? So there's a lot to be said out there, and all we can do as nurses is plug through and make our little piece of the world better. Okay? You make your little piece of the world better, you make your little piece of the world better, and it grows like an ink blot until eventually it gets better. Unless, of course, you want to become a nurse researcher and write powerful papers that change the world, like Holly Powell Kennedy. Okay. We talked about all those. I don't know why in an obstetrics books they want to talk about aging population with more chronic illnesses. It doesn't make any sense. And we already talked about childbirth trends.
So one in 5 in like 2030 it said that was going to be the elderly.
What's that? 1 in 5?
That was the
Okay. So definitely we're doing better on our older infant mortality. Okay, if a baby can survive 6 months or 30 days in America, they're doing pretty good in the long run. Okay, our infant mortality in the first month of life is not as good as it needs to be, but after 30 days we're doing much better. So we're having less sudden infant death syndrome than we used to have. That number has dropped by about half. We're not having babies die of malnutrition very often. We're not having babies die of exposure or infection or that kind of stuff. We're doing pretty good at keeping our older infants alive, and that's a good thing. But there is an increase in asthma, ADHD, and autism. How many of you, I love this number, how many in this room know somebody who has autism? If I had asked that question 20 years ago, what number do you think I would have gotten?
Maybe one.
Probably none of you, maybe one of you would have raised your hand. And nobody has the foggiest idea where that's coming from. It could be any number of things. It could be what we're using on the grass when we fertilize the grass. It could be what we use to replace asbestos in our insulation. It could be immunizations, although I don't think so. It could be birth things. It could be the woman that does the conscious birthing that I was talking about. She blames a lot of autism and violence in society on the birth process. That we are programming these children at birth by exposing them to something traumatic and frightening and scary the moment they're born. And so when she talks about conscious birth, she says maybe we can make that better. That kind of thing. So we don't know what's causing it. We really don't. Certainly there's an increase in recognition, right? It used to be autism was Rain Man, okay? The Dustin Hoffman movie with Tom Cruise. It was like 30 years ago for you in the back. So, so Rain Man, it used to be Rain Man, the guy who was incapable of living on his own and had to live in an institution, and he was, you know, whatever, that was autism. But it's not that anymore. Now it's autism spectrum disorder.
Yeah.
And it got bigger and bigger and bigger over the last 10 years. And what happened last year? They shrunk it. And oh boy, all the people on the fringe are going crazy. The NOS, not otherwise specified, kind of disappeared. And all of a sudden people got really upset. My autistic kid, he needs a... Okay, fine. But so there's definitely more recognition of autism. But now I've been working with children my whole life, okay? I've been a Cub Scout leader for a very long time. And in the last 5 years, I got to tell you, it went from I never had a kid with autism in my pack to now I've got kids with autism in my pack. And not just kids with autism. These kids are funky, okay? They're not normal, okay? They truly have, you know, very close to the Rain Man autism. I got like 4 of them in my Cub Scout pack. Where'd they come from? Okay, it's there. And it's on the rise. And so I don't think it's just recognition. I think that we're actually doing something to harm our children. And I don't know what it is. Okay? Asthma, same thing. A lot of people blame asthma on hand sanitizer, believe it or not. Yeah, hand sanitizer. Because what is asthma but an autoimmune disorder? Right? And so if you never expose the immune system to anything in their childhood, and everything is sterile, and then they go out into the world and they get asthma.
That's
because
why kids should eat dirt.
They should eat dirt. They should play in the mud. They should get all kinds of dirty, get infections once in a while. Run them to the emergency room and get them some antibiotics. They need it. You know? But here's an interesting thing. We talked about it briefly last year, and I promised I would talk about it more this year. The maternal microbiome. Remember talking about maternal microbiome last year? So the maternal microbiome is your environment on your body. Okay? And it's every bacteria on your body falls into what's called the microbiome. Okay? And it's yours specifically for you. And each one of you has a different microbiome. Okay? At birth, baby leaves your birth canal, where they've been picking up everything from inside your uterus, through your birth canal, and through your perineum, and up onto your skin, in their eyes, their ears, their nose, their mouth, and they've been seeding their mucous membranes with your bacteria. Okay? At birth, they go on your tummy, they lick your belly, they get more of that bacteria, they find the breast, they climb up, they get the bacteria from your breast. And what do all women want to do after having a baby? They want to shower. And what do we say? Don't shower! No! Baby needs that nastiness. They need it. They need to take it into their gut and get it through their intestines and seed their GI tract. Okay? And what we found is that when we culture babies at birth, there's a difference between, like when we take their stool and look at their stool, there's a difference between the stool of babies who are breastfed and babies who are formula fed. Not just the normal difference, bless you, in how it looks, but the bacterial makeup is different. Okay? What bacteria is in there is very different. Because, of course, breast milk is from the human body, and it has all of mom's bacteria with it. Whereas formula comes from a factory. And it's not sterile like a lot of people think, but it's close. It's food-grade sterile. Okay? So there isn't any E. coli in formula, or there better not be. There isn't any of the Clostridium difficile or any of the other minor pathologic bugs that have no effect on breastfed babies. Okay? Because the baby is being seeded by his mother's protective bacteria. He's getting the bad and the good at the same time. The same thing that enables you to carry E. coli with you all day, every day, and not get sick, because you've got your good guy bacteria protecting you. So babies get that. Formula-fed babies don't. Interestingly enough, when they did the same cultures on babies born by C-section, they had one bacteria. Only one. In their eyes, ears, nose, mouth, everywhere. Anyone want to guess what it was? What's that?
Yeast.
Nope. That's a yeast, not a bacteria. Staph. Staph aureus, exactly. That was all they had. Staph aureus. And where were they getting Staph aureus from? The hospital and the healthcare providers. Because they were delivered sterilely into a sterile environment, passed to somebody wearing a sterile gown, put on an extremely clean surface, and wrapped up in a blanket and kept perfectly clean in an effort not to get them sick. And what did they not get? Any of the good or bad guy bacteria. So you're going to read an article later on about the maternal microbiome. It's a little hard to get through, but read it anyway, and it's going to talk about why it's a good thing. There's an interesting story in there about sponges. There's a sponge that lives under the water on volcanoes. And that sponge, at birth, coats their offspring in a mucus that protects them from the environment of this, high pressure, underwater, volcano, hot environment, so the sponge can survive. And that little piece of evolution is what's allowed them to stay alive. And it's the same thing that we do with our newborns. At birth, we coat them with what they need to protect themselves, and then we give them more of it through our bodies. I always like to say that you'll hear people talk about a baby at birth has an immature immune system. They do not have an immature immune system. They have an incomplete immune system. They can't be complete without their mother's immune system. They need you to continue to support them. They're not designed to leave your womb and go to college. They have to grow up a little bit. And so they leave this environment and they join this environment. And they stay here where you protect them. And then gradually over the next 4 to 6 months, they start to leave the mother's environment. And they start to develop their own. And so it's fascinating stuff. Oh, we're going to have so much fun. But anyway, so that's where we're thinking that asthma might be coming from, is that we're not preparing our children's immune systems for the outside world. And unfortunately, once you get asthma, what do? But we say, knock it off. Nothing dirty ever again, right? Get rid of all the allergens, and it only makes it worse. I mean, they survive, but their asthma is not going to get any better. They just learn how to live with it. Yeah.
Even food, like they even restrict some kids from food.
Sure. Did you know, I read once that 1 in 4 children exposed to soy formula will have a peanut allergy. 1 in 4. Yeah. That's interesting stuff. 1 in 4 children will get a peanut allergy. Yeah.
Can asthma be also like environmental though? Because my sister used to live here in El Paso, and she has an inhaler now where she has
It's the more accurate way to look at that is it's immune system. It's an allergy. Okay, it's allergically mediated. That's the word I'm looking for.
Dust out
Yeah,
there.
it's whatever is there she doesn't like as much, and she needs to move. She's allergic to where she is, and she needs to move away.
Well, her husband's in the military, so she.
Sucks to be her.
Yes.
I met a friend, one of my good friends in good catch. Only got a little water on me. So, one of my good friends in lactation, her son is a helicopter pilot, and he's been in the Army for 18 years, and he's stationed in Kansas, and he is desperately allergic to Kansas. So bad that he can't fly anymore.
Oh no.
He's that allergic to Kansas because he can't survive without these allergy meds, and the allergy meds ground him. He's never had allergies before, he's never had asthma, now the kid's dying on a regular basis. And they have to move him out of Kansas so that he can fly again and go back to being himself. Sad, isn't it? But yeah, there are...
Kansas?
Yeah.
I have most allergies.
What's that? Fort Riley?
Or Fort Leavenworth.
Mm-hmm. But, so, understand that I'm not an asthma expert, but in general there are 2 asthmas. There's an allergy-mediated and an autoimmune-mediated. I'm sorry, there's an autoimmune-mediated allergy, and that asthma, and that falls under the allergy heading. There's 2 headings there. And then there's a psychologically induced asthma, where anxiety leads to breathing funny, leads to a drop in your CO2, leads to a panic attack, which looks an awful lot like an allergy attack, and your bronchial spasm, and it's, for all intents and purposes, an asthma attack. But it's just it's triggered by something else. Okay? One is immune system, the other is psychologically. And we see that, by the way, all the time in birth. Okay? You'll see an awful lot of women hyperventilating and having trouble breathing while they're pregnant and giving birth. And it's because of this. And it's not anyone's fault. As your uterus grows, it pushes everything that used to be here up into here. It makes it hard to breathe, right? So if you're somebody who's always sensitive to the idea that, I can't breathe, and all of a sudden you literally have a 30-pound thing pushing on your lungs, it becomes hard to breathe. And that wears on you. Breath after breath after breath, and it gets worse and worse and worse. All right, so women and families, access to health insurance. This should be a non-issue, right? Because the Affordable Care Act mandated every single person in America now buys insurance, and so therefore everybody has insurance and all problems are solved, right? Right. Yeah, right. It doesn't work that way, right? Because it doesn't do you any good to mandate that you buy. I could force all of you to buy a BMW. Doesn't mean you could go buy a BMW, right? Doesn't mean you can afford it, and it doesn't. And so it's not as easy as that sounds. But in countries where they have socialized medicine, like I was talking about in the military, it's not much better. Okay? It's just not. Because there's two aspects to it. One is having the care available. The other is thinking it's important to use it. Okay? And if you don't think it's important to use it, you'll never use it. You know, my doctor tells me to eat right and exercise, and I tell him no. I know the right answer. Am I going to do it? No, because I don't think it's important. Right? So I'm never going to go down that path until someday I decide it's time for me to do it. Okay? But healthcare is available. It's just not free, and what isn't free is not used. You know, that's just the way it goes. But we believe that there is a certain amount of healthcare that all pregnant women need. Okay, that they need to be checked at least a couple of times. There's actually some pretty good evidence out there that if a woman goes to 4 prenatal appointments during her pregnancy, her risk of complications drops dramatically. Okay, only 4. And they don't have to be any particular prenatal appointments. Just 4 times you see your provider during your pregnancy. Drops it dramatically. That's an interesting finding. Okay? So, but it's sometimes hard to get people to do it. I have it happen all the time. My wife, baby numbers 6 and 7 and 8. It's like, why bother? Why go? You know, you'll know if there's anything wrong. Yeah, like I got a magic wand. I can take your blood pressure by doing this. I can't do that. And I don't have a sphygmomanometer at home. I can't do it. You know, I'll know if there's anything wrong. Okay, you'll know. I can't tell her anything. And, you know, you could blame it on the fact that she's, you know, married to a midwife and she has 8 kids. But no, it's just she doesn't value what they do when she goes to her appointments. She doesn't think it's worth it. You know, it's not worth the effort that it takes to get there. And there is a real problem, is one, helping families understand the value of healthcare during pregnancy, and 2, making healthcare valuable to people who are pregnant, okay? Because how many of you, during your pregnancies, went in, they weighed you, they took your blood pressure, you saw the doctor for 30 seconds, they measured your belly, listened to your heartbeat, any questions? No? Bam, out the door. How many? All over the place, okay? That's not healthcare, okay? That's checking the box. I once knew a doctor who was extremely proud of the fact that she could see 60 patients a day in a routine OB clinic. Oh, yeah. If I see 18 or 19, I'm having a rough day, okay? And she could see 60. She didn't see them. The nurse took her vitals, measured the fundal height, listened to the heartbeat, and all the doctor did was go, hi, how you doing? Everything's great. Your numbers are looking good. You're doing perfect. Any questions? No, I'll see you later. Hi, how you doing? Everything looks great. I'll see you later. You know, that's all she did all day. She wasn't seeing them, okay? But, you know, it was a very efficient model. But she wasn't providing any health care, and certainly her patients probably didn't feel well taken care of. And I would expect her to not have a lot of patients who made every single appointment, okay? Because they wouldn't value that kind of care. So we got to find a balance, okay? And of course, increased heart disease, we already talked about that. And women are not nearly as healthy as we'd like them to be. Health policy decisions. I'm going to skip over this one because I didn't read this part. But I'm dead curious. What does the book say about this? We're in chapter 2. You know, you've read something 10 or 15 times and you skim through it, and I didn't read about it.
I mean, it basically said that it's always changing and that, you know, there's always going to be different views and it's not your job to impose your political influence or whatever on your patient to just, you know, support
Got it. Okay.
The patient, what they want. But to be aware of, like, the political stuff that's going on concerning your job.
Yeah. Okay. Sounds good. So there's, you know, a lot of interesting debate going on in the country about abortion again, isn't there? Mm-hmm. There always is. Every time the Supreme Court tries to solve a problem, they end up just making trouble. Yeah. Such is life. But that's okay. So I actually am involved in a debate right now with a friend of mine from New York, and we're bickering back and forth about abortion and that kind of stuff. It's kind of fun, you know, because, you know, I'm not going to change her opinion. She's not going to change my opinion, and it doesn't matter anyway. But it's fun to bicker. As you know, the 9 to 10 kids and a whole bunch of boys, I love to debate. I love to fight. It is so much fun. It is. It's so much fun. And it doesn't mean anything, but I just love to do it. It's so cute. But know that, yes, abortion is out there. Abortion exists. You're going to meet people who have abortions. It is the number one, I believe, the number one most common surgical procedure. Well, I don't know if I can say that. It's only like 1 million a year. Are there that many C-sections? Yeah, there are that many C-sections. Okay, never mind. Not the most common surgical procedure. But it's a very, very common surgical procedure. And you guys understand that there are 2 abortions, right? Mm-hmm. Okay. Abortion simply means the end of the pregnancy before its time. Okay. There's a spontaneous and then there's an induced, right? And then there's under the spontaneous there's a whole bunch of subheadings that we'll talk about: missed, incomplete, imminent, threatened, that kind of stuff. Okay. Mm-hmm. And then there's the elective abortion, which is a totally different thing. And most of the time we use miscarriage to describe one and abortion to describe the other. They're both basically the same thing. It's just a matter of what's the source, what caused the problem in the first place. Okay. Currently, abortion is legal with one restriction or another in all 50 states, and so you are going to see it. My experience with it is that while there's an awful lot of really good evidence out there that says that most women who have abortions are satisfied with their decision to have abortions, that research is done on women within a year or 2 of having the abortion. Okay, it's not done 5 or 10 or 15 years later. Okay, and my experience as a healthcare provider is that when you talk about it 5 or 10 or 15 years later, when the big problem that was going on at the moment is no longer there, there's much more, it's not nearly as clear-cut anymore. All of a sudden it becomes, ooh, I don't know if that was a good idea anymore. It seemed like the thing to do at the time, but now not so much, you know. And we know that women who have abortions do have associated health problems with it. Difficulty conceiving, a higher risk of miscarriage on the next pregnancy, that kind of stuff. So it's not a, you know, I like to say that nothing in life is free, okay? With everything, epidurals, abortions, you know, narcotic pain relievers, everything. There's blowback to it, okay? WIC, we all know about WIC, right? Mm-hmm. Okay, so women and infant children is what it's called. We talked about it during the nutrition class, didn't we? Good. We'll skip it. Medicaid, did you guys know that Medicaid is available for basically all women? That anybody can show up at a hospital and say, I'm pregnant and I need care, and Medicaid will cover them, at the very least for that acute appointment. Okay? It becomes an issue later, okay? But there's no such thing as too poor for Medicaid, okay? It's everybody, you know, and so at its basics, everybody is covered a little bit. For pregnancy care. The issue is when you make just enough not to qualify for Medicaid, but not enough to really pay for what you need. And that's where we have problems, is there's a gray area there. You guys maybe, if you were following the news over the summer, you know, Seattle went to minimum wage is $15 an hour. Mm-hmm. And then what was the blowback from that? Did you hear? Because there's nothing's a free, there you go, less hours. Because if I'm working 40 hours a week at $15 an hour, now I don't qualify for Medicaid or food stamps or all the other benefits I was getting. It's now more expensive to live than it was when I only made $7 an hour. Isn't that an interesting experience? That cracks me up. I'm like, with good intentions, but darn it, always something happens. Again, there's no such thing as a free lunch. Okay, with everything one way, you have a response in the other way. Good or bad, doesn't matter. But there's always something you have to, there's always an unintended consequence that you have to think about when you're moving through whatever policies you're thinking about. Okay? Mothers and Newborns Health Protection Act. And then we talked about the Affordable Care Act. I'm going to skip. Okay. Vulnerable populations. Absolutely. At no time in anyone's life are they more vulnerable than when they're pregnant. Okay? It's a big deal, right? And so even a well-resourced person is vulnerable during pregnancy, but they are particularly vulnerable when they fall into these categories. Okay? And as nurses, we're going to see that an awful lot, and we need to be aware of it, we need to be conscious of it. That just because somebody shows up in your hospital having a baby doesn't mean that they have a happy home. Doesn't mean that they're not in an abusive relationship. Doesn't mean that they have food on the table or that they have the ability to care for this baby when you leave the hospital. There's an awful lot of folks out there who are in trouble, who need help. Obviously, a homelessness, and you can read that just fine. And so part of the job of the OB nurse is when you do your intake physical, when you do your intake assessment, you're going to ask an awful lot of questions, And some of them are: do you have enough food at home? Do you have the ability to care for this baby when you leave? Is there anything we need to do for you while you're here? The beautiful thing about pregnancy is, for most women, pregnancy is the first time they ever access the healthcare system. The first time they ever access anything other than their own personal family. It's the first time that they get a physical exam, first time they get a pelvic exam, first time they've ever had anybody assess their home environment, first time anyone's ever asked them if they're safe at home. For an awful lot of women, this is the first time they enter the system. And they're entering the system talking to you. And it's your opportunity to find the vulnerable populations and fix them. And try to get them the resources that they need. Okay? The resources are out there, they just have to be gotten. Sometimes they're harder to get to than others. I'm frequently frustrated by the bureaucratic red tape that we have to go through for everything. Okay, it drives me absolutely bloody crazy. It's there. And so when women, nurses who are working in maternal child health become very adept at finding the resources that they need, whether it's through social work services, whether it's through a family advocacy type program, whether it's through a pregnancy crisis center, but you develop a toolbox of helpful tools, things that you can use to get the women the care, the families the care that they need when they're no longer in your hospital. Okay? Interesting experience over the summer. I went to the La Leche League World Breastfeeding Week celebration. I posted it on Instagram. It was like one of the few things I've ever posted on Instagram, where I set up a table there and I was doing dad's role in breastfeeding. That's my niche, right? And so I was going through, having different families, and this lesbian couple came up. And it was an interesting experience. I had not had a lot of experience with lesbian couples in pregnancy. And they were both active duty soldiers. One was very pregnant and the other was her partner. And so they were asking about what her partner could do to support the baby when the baby comes out. What was her job? If I'm talking about the role of the father, well, she's not the father, but she's definitely in the father's role, right? And so we were talking about it, and a lot of it is the same stuff that dads can do. Anybody who cares can do that work. They don't have to have a penis to qualify for the job, right? And so, but then I talked. There's a dad's boot camp on Fort Bragg, where it's dads helping dads. Because men, we speak a different language. And it's a wonderful thing for that. And she said, well, would I be welcome in that group? Could I go to dad's boot camp? And I went, well, yeah, I don't know if you could. Because, in a sense, what we're looking for is the coach's boot camp, right? We're looking for the coach to have a role in the environment. And yeah, definitely, they qualify. But I don't know how well she speaks boy. I don't know how well she understands boy language. Because there's definitely a difference between boys and girls in how we speak. We use, boys tend to like analogy and humor and that kind of thing, and girls tend to not. Not that, if you do, fine, but these are broad picture things, right? Like the reason that men know so little about breastfeeding is everything is pink and pastel and pretty. That's not me. I'm not pink and pastel and pretty. Do you see what I wear? Earth tones. If you want to bring a guy in, they have to be colored like this. They can't be colored like that, okay? We don't do pastel, okay? And it turns us off to see pastel. We walk in a room and it's all pastel, and like flowers and... So I don't know how much, I don't know where she would fall, where, a same-sex partner would fall in that. And so I found myself going, gosh, I don't know. I'll help you. Here's my card. Call me. We'll talk. I can't speak for them. I'm not in the group.
Yeah.
You know, I don't run that program. I can just tell you it exists. Okay. So, but it was my first real experience. Dozens of lesbian couples, but it was the first time I was ever put on the spot. You know, with that. Most of the time, it's just kind of a hint. You know, this is my good friend Shirley. You know,
Yeah.
you know who she is. And then there's, of course, substance users. Substance users is a fascinating debate that's going on right now. Did you guys hear? In Tennessee, they made it illegal to use drugs when you're pregnant.
Yes. Mexico and stuff.
Holy cow! It wasn't illegal before? I thought it was always illegal to use drugs when you're, whether you're pregnant or not.
Yeah.
Okay? Excuse me. But the point was that they were doing a mandatory reporting of drug use in pregnancy. That anybody who was, you know, smoking pot or on crack or whatever, or crystal meth, that they would be referred to social work services and, you know, perhaps incarcerated from that. And there's a whole lot of dust up on either side. Okay? One side says, well, duh. Okay? It's probably not a good idea to skydive either. It's a little dangerous doing that stuff. We know that that puts babies at risk. But the other side said, yeah, but when you make it like punitive, she's not going to seek the help that she needs. And she's going to, she and baby are going to suffer because they're afraid. And then you're more likely to like deliver at home, unexpected, that kind of stuff. And so, while home birth is a wonderful thing, it should be a planned home birth, not an unplanned home birth. You know what I mean? And so, it's a very interesting debate. Because, yes, you want to keep people away from drugs when they're pregnant. Absolutely. You want to keep them away from drugs when they're taking care of children, too. 100%. But how much stick can you use versus carrot in making that better? You know? And unfortunately, just like abortion, just like any other number of things we've talked about, your own personal emotions play in too much. Too much, some people have a strong sense of justice. It's just not fair that they're using drugs. And it's illegal to use drugs. And we need to stop them from using drugs. You know, that kind of thing. There's that sense of justice. Okay? And then there's the other side where, you know, where it's not their fault. And, you know, there's so much to be said for drug use as a disease process in the same way psychiatry or psychologic diseases are a disease process over which they have no control. Okay? And so, and I don't have the right answer for you, and we don't know it yet. Okay? There's definitely something to be said for addiction as a disease, but how you get to addiction as a disease when your own personal actions lead to a disease is where we start to get gray. You know, obesity is a disease, but very few people are born fat. They make themselves fat. You know, I'm one of them. I like to say that I've never seen a skeleton with a double chin. Okay? When you get rid of all this, we're the same bones. There's no big bone. We are what we are. And we got there by too much hand-to-mouth disease. Okay? And so that's one of the reasons that obese people have such a barrier to accessing health care, is that when obese people access health care, their health care providers put a judgment on them. Yeah. You are fat because you made yourself fat. The same thing. You are a drug addict because you made yourself a drug addict. You know, it's all, you are poor because you made yourself poor. That we throw these barriers in the way, these judgmental barriers that stop us from being effective healthcare providers. Okay? And so the thrust behind public health, and really this whole chapter, is knowing what is out there and how can you avoid your own personal judgments when you're caring for that family. Okay? Because no matter how they got themselves in the situation they're in that situation and you're the nurse. Period. Okay? And at the end of the day, you're responsible for what you do. Okay? You're responsible for how well you care for these families. Okay? When you start to use judgment, you start to cause problems. And so you can have all the personal opinions you want. You just got to keep them in check and keep them away from this. Okay? Because when your personal opinions hit your face, everybody sees it. Okay? So you got to watch it. So we talked about this earlier, did we not? About our social care. I love the concept of autonomy. Okay, who can tell me how autonomy plays a part of birth?
As the patient, or?
Period. How does autonomy influence birth?
Also, how you like the whole, it's my birth with my consent.
Mhm.
And like they have a right to decide what type of treatment and what they decide they want for their birth.
Perfect, okay? Yes, women have 100% control over their own body. What's the problem with that statement?
That sometimes, you know, that there might be something better for them because you have the medical expertise and they
Well, there's that, but that's not really what's important. What else is there?
beliefs and culture and.
When a pregnant woman walks into a room, how many people are in the room? Two. Okay? There's a baby involved. And oftentimes, mom's autonomy is put on the side for baby's protection. Okay, remember we talked earlier? In current American culture, baby's wellness is the absolute most important thing. And that we will torture women in order to get healthy babies? We sure will. And there's where autonomy starts to be a problem. Because obstetrics is not like any other kind of medicine. Okay? Even pediatrics, we allow people to have control over their children. Right? In birth, we do not. In birth, there are dozens and dozens of court cases of women being forced by court order to have C-sections. You'll never see that anywhere else. Okay? Your doctor can't force you to have a triple bypass. He can't force you to take your insulin, but the court can order you to have a C-section. How impressive is that? Because there's two patients, right? And there's a problem there. In upstate New York, if you refused your vitamin K and eye ointment at birth, there was an automatic social work services consult placed against you. Automatic. No, there was mandatory reporting. If you said my baby can't have a shot of vitamin K, instantly social work services came to see you because you were potentially putting your baby at risk. Isn't that interesting? So much for autonomy, so much for being able to choose your own care, right? And there are laws like that all over the country. Some good, some bad, but all over the country there are laws like that. There are laws even worse than that, far more draconian. There was a wonderful article came out of Tennessee a couple months ago, well, probably about a year ago now, where this one neonatologist recognized a sudden increase in vitamin K deficiency blood disorders among newborns. And it was 4 babies in 6 months out of a home birth population. And it was this home birth provider was not encouraging vitamin K injections at birth. And it made national news. It went all over the place. Oh my God, they're unfit mothers because they're not doing what I think is important. Okay? Oh, they put all kinds of fancy words about it. Increased risk here, doing this, doing that. But what they were really saying is, you're a bad mother because you don't agree with me. And unfortunately, that's a big problem in American obstetrics. I know you've all experienced it. You hear it on the breastfeeding, formula feeding debate all the time. You hear it on the co-sleeping, not co-sleeping debate all the time. There's an awful lot of judgment that goes into that. And so it's important when you're the nurse and you're taking care of people that ultimately mom has autonomy. Whether you want to give it to her or not, she has autonomy. You know what else mom has? Responsibility. If her baby dies, was that your baby? Do you live with the grief if her baby dies? No. I frankly could care less. I can only offer. I can't make it happen. Our role is to offer what we think is appropriate. They'll take it or they won't take it, and then we leave it alone. Okay? Because we don't have any choice. We can't. Okay? There are laws that protect a little bit, but not much. But all those laws run afoul of common sense, do they not? It's like, woo, I mean, do you really feel the right to force people to have abdominal surgery? I mean, that's appropriate? Well, yeah, the baby might die if you don't have abdominal surgery. Doesn't mean he will die. And whose role is it, why is it your job to keep the baby alive? You know what I mean? So there's an awful lot of debate when it comes into that. And some of it is perfectly appropriate. And some of it is, not so perfectly appropriate. But know that you're going to run into it over and over and over again. That autonomy issue in birth is a particularly sticky problem. Because there are 2 patients. Because, your right to control your body only goes so far when you've got another body inside of you. And it's difficult. Okay? Alternative therapy. I got to tell you, this is definitely a big deal in obstetrics right now. Complementary and alternative medicines or medical care is a huge thing. There is more to this than we know. Okay, and I like to tell patients that we are standing at the brink of the abyss, and in front of us is a huge environment that we know nothing about. Okay, and I think it's arrogant to say things like, "Oh, euthanasia doesn't work." What do you know about euthanasia? You know, just because you've never heard of it doesn't mean it doesn't exist. Doesn't mean it doesn't work. Okay, and so when I'm talking about this, I'm talking about like herbal supplements. I'm talking about the non-medicines that people like to use. The other day, someone handed me this something for pain. I'm forgetting what it was. It was like a rub. And you just rub it on your hand, and all of a sudden the pain is gone, wherever the pain happened to be. Not on the hand. Like, you know, it hurts. If I put it on here, and my knee's going to stop hurting. Yeah, it's an oil. It's essential oil. Yeah, exactly. I forget the name of it, but they were like, "Oh, how have you not heard of this? Try that, try this." And it's fascinating.
Probably doTERRA.
What's that?
doTERRA.
doTERRA?
Is a brand of essential oil.
Could be. Could be, yeah. But there's all kinds of wonderful stuff out there that we just don't know. All kinds of interesting stuff. And I love when people say, you know, well, a medication is controlled, and you know what's in a medication, blah, 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 blah. And, you know, a medicine works so much better than an herb, right? Okay. Does anyone know where aspirin comes from?
Tree bark.
Tree bark.
Tree bark. Yeah. It's willow bark. That's all. You can strip a chunk off a tree and eat it, and it has the same effect as aspirin. Isn't that fascinating? And penicillin comes from fungus, right? There's actually some stories from the slave days in America. There was a folk medicine practice. They would take cow dung and put it in water and then let it mature, and it would grow this cake on top of the water, and then the slaves could eat that when they were sick. And of course, you know, people are, "Oh, please, folk medicine, how awful is that?" What were they growing? Penicillin. They had discovered penicillin long before Fleming discovered penicillin on a piece of toast. Okay? And so it's fascinating to think about our folk medicines and what we dismiss now and what it's going to become later. Okay? So complementary medicines is an area that's going crazy in the birth arena. Guided imagery and what's that that chakra? What's it called?
Reiki.
Well, Reiki is one of them. The one I'm thinking of is
For the rocks, they use rocks, they probably.
no, it's like I had a what's that?
Tai Chi?
No, it's like you put the patient on the bed, okay,
Bells.
and then no, you just run your hands over them like this,
Oh.
and you don't actually touch them.
That's not with the energy or something?
Yeah, but you're adjusting their energy flow, and I can't think of what it's called right now. It's specifically mentioned in your book, but it's fascinating because our problem isn't does it work or not. The problem is how do you know if it works or not? You know, we don't know if it works or not, and we have a hard time measuring whether or not it works. Okay, and the fascinating thing about the body is whether it works or not. Most of the time is up here, not in the actual part, but up here.
Because if the person thinks it works in their mind, then they're probably controlling their own pain, but
Exactly.
they're giving credit to whatever if they're getting done.
That is
But
certainly.
really, it's probably their mind just controlling it.
And that is certainly a part of it. The opposite argument to that is it really does work, and you're discounting it by saying it only works in the mind.
Yeah.
You know what I mean? We don't know one way or the other, you know? When I was a nursing student, one of my nursing professors told us about the clinical trial she did during the Vietnam War on amputee patients trying a brand new drug called Obi-Cal. Have I mentioned Obi-Cal to you guys before? Obi-Cal. It was an amazing drug. It was going to replace all narcotics. You could have these guys with incredible pain. You give them a shot of Obi-Cal. Man, they're better instantly. Obi-Cal is placebo spelled backward. It was plain old normal saline. But they were giving it to these guys and they were having an immediate response. Okay? And the same is said for when we use narcotics in labor. Okay? When you go to somebody in labor and you're saying, this is the best thing in the world, this is going to make it so much better for you, I'm going to give you more than I normally give because I know you're in pain. And you give it to them, it doesn't matter what you gave them, they're automatically better. It's amazing how it works. When you say things like, well, I don't know if it's going to work or not, sometimes it does, sometimes it doesn't, it doesn't work as well. Okay? And that part definitely is up here, right?
Yeah.
Okay? But the question is, how did the pain go away? The pain went away, right? They're more comfortable after than they were before. But how did it go away without a narcotic pain reliever? There's more to it than the brain just said go away. Because if you say that, then you're saying the brain has an incredible amount of power. More power than you've ever considered. More than you've ever tapped. Think about how powerful the brain is if it can make asthma go away because you want it to. If it can make asthma go away because you did this. And all of a sudden they're not in pain. How amazing is that, right? And so that's that complementary and alternative medicine. And I don't want anyone to get the thought that I'm dismissing it at all. I think there's more to it than we know. I think that there's more, there's things that we can't measure yet, and they are there, even if we can't measure them. A very good friend of mine, I did my doctoral work with her, she's studying phantom pain. And phantom pain is fascinating. Yes. That the body perceives the joint as there, even though it's not there. And they have a lifelong image of that as there. And I've not done any of the reading on it, so don't quote me on this, okay? But she talks about these guys who got their arm blown off while they were throwing a hand grenade. Like the hand grenade exploded and their arm was like that. And in their mind, their arm is still here. And it's in this position. And they can't walk through a door without turning and making room for the arm that isn't there. Because their brain sees their arm this way. And it hurts like you were holding your arm up all day long. The muscles ache and they burn because they can't put their arm down. How fascinating is that? Because it's imprinted on the brain somewhere that that arm is still there and it's in that position. Okay? And no matter what happens, they live with their arm in this position. Isn't that cool?
But I thought also one of the treatments for that in particular was that they would have a mirror that they would have down
Exactly.
close to that.
There was a thing where there's a mirror that you put somewhere so they can see the other arm, and it tricks the brain into believing that arm is there. Not that it absolutely works, but wow, how amazing is that? Talk about complementary and alternative medicine. That's not drugging them, right?
Right.
That's reprogramming the brain.
Doctor, I forget his name.
Yeah. Yeah, so my friend, she was studying that. Right now she's doing work with lasers on plantar fasciitis.
Oh.
You go where the grant money is, right?
Yeah.
But just know that when it comes to complementary alternative medicine, there is far more than we give credit for. And it's arrogant to assume that something doesn't work just because you're not familiar with it. Okay? It works, whether you're familiar with it or not. The world is what the world is, whether you agree or not. And it's there. Okay? Have you guys had enough? Mm-hmm. Like 3/4 of you are like, So we're going to stop.
Just to clarify, our lab starts next Wednesday, not tomorrow.
16th, right? No,
The 26th.
26th.
And
You
we
did
have,
it the 6th.
we won't meet at all again this week.
Correct.
Okay.
And it's at 8?
Next time we meet is the 25th. At 1 o'clock on the 25th. All right. I need my daughter's markers back.
They're right here.
Good.
I have some.
Now, 2 choices. Let me have these back. Okay? So pass all the name tapes this way for me. What? Not yet, but I will.
That's a good, like,
That
charade.
area is tough.
I didn't scratch it yet. login information, because I don't wanna,
Email.
mess it up for you.
Yeah.
By the way, next week is 5 and 6, right?
Yes. Are you 6 and 7? 6 and 7. 6 and 7. 5 and 9 is the last.
Oh, thank you, okay. 6 and 7. Whatever's on the schedule.
Gonna go yoga.
How wonderful. I like yoga. I do it, well, when I exercise, yoga is the only exercise I do. And my kids, they don't understand it. I'm like, you gotta bring the intensity. Oh, sure, it looks easy, because you're not bringing the intensity. Yeah.
Redeemed the freshman of 25, whether in your junior year.
Nice.
So, did it stop raining? No, it's
And remember, if you want access to the YouTube channel and you haven't sent me your Gmail address, please send it. Nothing on YouTube is going to be testable, but it will enhance your learning experience.